Recording. Great.
Okay.
And my slideshow is running. All right. So thank you very much. Appreciate everyone taking the time to join us today. My name is Dane Christensen from the Health and Medicine Council. Many of you know me. For those of you who don't, I want to be clear about this. We are a grassroots network, and our strength comes from all of you and your willingness to share your stories and experiences with members of Congress, including through events like the Stampede. They're not that interested in hearing from me or Dylan. They're very interested in hearing from you. Not only do they represent you, but they know that you have a pure self-interest, and that when they're trying to talk about different issues in the healthcare system, be it with drug companies or specialty pharmacies or insurance, what matters most to them is how is the system working on your end? How is it working for you? And your own personal experiences are very important in that regard. So together, we ensure that there's a critical mass of support on Capitol Hill, both in terms of awareness and education, but also the ability to work on the issues that are pressing. And that those issues usually run a spectrum of where the government gets involved in healthcare. It all starts with research. One of the presentations that Sonia mentioned that's already posted. What do we do to invest in research? Make sure that there's a lot of resources going to controlling and eliminating cancer that is already disseminated. That then fuels breakthroughs, and it fuels advancements in treatments and patient care, which we then move on to the Food and Drug Administration and the ability to get new products approved and indicated and usable and out to market for folks who need them. And then once you have products coming to market, unfortunately, as a result of advocacy, we have seen, and really good research, we have seen ongoing innovation in the space and new breakthroughs and options. You end up working in what's called coverage and access. So what are your out-of-pocket costs? Are you getting the medication that your doctor thinks you need that is part of your care plan? Are you preserving that physician-patient relationship? All of that has to do with coverage and access issues. Are you getting what you need when you need it? And are you paying a fair or appropriate price? Are you not being steered to something else? Are you not having your judgment questioned? Are you not being diverted to a different product or getting a surprise bill? Those are type coverage and access issues. And of course, you are an expert on what's been happening with you or other folks you know from the community. You do not have to be an expert in civics and government to be effective. You do need to be an expert on your story or the stories of others, or kind of the broader experience. We are doing a deep dive though, so we're going to try to make you an expert today. This is about a 15-minute presentation. There'll be a Q&A session at the end that won't be recorded, but this is the third of our specific issue presentations. So we did a kind of a general how our government works, and then we talked about specifically how do we increase funding for medical research and ensure there's an investment. And then we talked about a different coverage and access issue called the Metastatic Breast Cancer Access to Care Act, which has to deal with disability fast track benefits for Medicare and SSDI. And now we're talking about the Cancer Drug Parity Act, another specific issue. So I also want to mention that there's going to be a comprehensive session, a kickoff, that'll be happening on October 4th. And there'll be a mandatory training if you're doing the Stage 4 Stampede on the 17th, where we'll all be getting together in person. And if there was a way I could summarize this presentation in a brief statement, it would just be that health insurance is complicated. So we're going to talk about how some of those complexities might make things unfair for the community and what we can do to fix it by talking to our members of Congress. So really quickly, what is the broader state of play in terms of coverage and access issues? So innovation often outpaces regulation. The government works very slow. They don't pass bills very often, and they rarely make kind of comprehensive updates. But when they do, they make those decisions and they make those changes based off of input from their constituents, people like you, who take the time to talk to them. The squeaky wheel gets the grease, that old axiom. So really quickly, what has been going on recently? I think folks know that about 12 years ago, Congress passed the Affordable Care Act. It was a comprehensive update to healthcare. It dealt with a couple of specific issues. It said dependents can stay on family coverage until they're 26. It said that they're going to do away with lifetime and annual benefit caps. And it provided something called guaranteed issue. It said that you must be able to get a health plan. No one can deny you a health plan. And it also set up the health and care insurance exchanges, which are now commonplace. But all of those things occurred because Congress had been hearing about these issues from constituents, along with another issue called a rescission, where people had their health insurance canceled retroactively for some technical reason. Policymakers said none of this is fair, it's bad for patients, we're going to change the law. The law did a lot of other things, but those are the specific things that we were interested in, and that was the vehicle that Congress used to make these changes and add these new protections. Not a perfect solution, but incremental improvement. You put one foot in front of the other, progress takes place. More recently, Congress dealt with something called surprise medical billing. They did this in 2020. It's being implemented now. It started being implemented last year. Surprise medical billing was another issue they could coalesce around on a bipartisan basis. There were very polarizing debates happening on other topics, but they do only work where they can work together. And both parties and both chambers said, we have to end surprise medical billing. This is when, if you go out of network, you might not even know that you've gone out of your network. You might be got a referral and went somewhere you shouldn't have, and then you get a huge bill in the mail. Congress said, this is unfair. We have to change this. And we certainly have to make sure, even if a mistake was made or something happened, that the patient isn't the one paying for this. Why would the patient be responsible for seeing a doctor that was out of their network or going to a specialist? This is between the physicians and the insurance company to sort out. It's not between the patient to have to foot the bill. It doesn't make any sense. So those fixes are being made now. I think some of you may know Congress is now working on something called PBM reform, pharmacy benefit manager, trying to add transparency into an opaque process. Drug companies and payers are negotiating prices. What does this mean? How much do you end up paying? They're trying to sort all this out. But this will become a vehicle for many other healthcare bills, things that are very popular with the patient community. One of them, something called the Safe Step Act, which deals with step therapy, is already included in the Senate proposal. There's talk about including something called the Help Copays Act, about making sure copayments are included in there. So this will not just be about PBMs. It will become a vehicle for other healthcare bills too. But the only ones that end up in a final package will be the ones that both parties and both chambers agree are good ideas, middle of the road, consensus positions. And fortunately, nothing we are talking about today has a partisan tinge to it. What we're talking about is common sense reforms, but we're trying to overcome an obstacle of a lack of awareness, make sure that there's more support and Congress is ready to deal with this. The timeline that Congress usually works on is 2 years. So even as we talk about pushing some of our issues forward, we probably mean before the end of next year, the end of the Congress, not necessarily the end of this year. If something doesn't pass by the end of next year, the end of the 118th Congress, then it has to start the process all over again. But our deadline is not this December, it would be next December. So just so folks know as they approach some of these discussions. So let's do a little bit of a primer on coverage and access, like how the government is involved in coverage and access. So certainly, as we know, this is a dynamic time, but there are some programs and things that we're all very much familiar with. And these are things that Congress works on too, your elected officials. So we have federal coverage and access programs. This includes the VA, if you're part of the VA health system, and that's where you receive care or your benefits. There's something called TRICARE, that is for the Department of Defense military personnel and their families. So soldiers, sailors, and also usually the folks that live with them, their spouses, their children. That's TRICARE. We also have Medicare and Medicaid. Medicare, of course, is both an age and disability-based program, and Medicaid is a needs-based program, but these are coordinated by the federal government. There's also a lot of folks who still use private insurance, and private insurance is actually regulated through the Department of Labor, because going back a long time, we had employer-provided healthcare, so the Department of Labor has a role to play. But in any of this, there are some key benefits that pop up. There's a hospital benefit. What's your cost obligations and what happens when you go to the hospital or an inpatient setting? We have a pharmacy benefit. What happens when you're at the pharmacy counter? What is your copay? Things like that. We have supplemental coverage. So you might be in a specialty drug program, you might have wraparound coverage or additional coverage, paying for a little bit more to lower costs further. And then, of course, there's a number of assistance programs. This includes things like premium, copay, and travel assistance, maybe some type of infusion assistance. But all of this is part of that larger healthcare network and things that the government is involved in. When Mediviver and the community are talking about these coverage and access issues and figuring out how to sort through a lot of the noise that's going on Capitol Hill or in policymaking, there's really two things we look to. The first is we always say all products, all sites of care. Patients need multiple options. They need that innovation that goes on at NIH and FDA to turn into multitude of products that are available. There should be competition in the marketplace. There should be options, and patients shouldn't be steered one place or another. They shouldn't be told you have to use your hospital benefit because it's cheaper, or we're going to make you use your pharmacy benefit because that's the way it's set up. All products, all sites of care. You and your doctor know what works for you. None of these things are the same. That's why they have approved drugs. The other thing is preserving that physician-patient relationship. Are you and your doctor allowed to create that care plan and move it forward, or does someone else get involved? Is there a bureaucrat that might not know you, or a payer, or someone else, a PBM that's saying, we're going to do this instead? You and your doctor should decide what your course of care is, and nothing should really disrupt that. And the other part is we try to lower out-of-pocket costs as much as possible. It doesn't make sense saying you're footing the bill for this or most of it. This is what these other programs are for, and we want to lower those out-of-pocket costs. And we certainly don't want any out-of-pocket costs to become a barrier to either physician directed care or that all products, all sites of care axiom. So where does Congress come into play? You have an insurance company or you have Medicare. What does this have to do with our elected officials? Our 100 senators, our 435 members of Congress. And whenever I talk about this, I always try to stress that every single legislator can have an impact on any issue. I also want to say there are a lot of local offices. So we talk about the people that are doing policy work in DC, writing bills, working on legislation, the folks that are in Congress. These are who we see in person during the Stage 4 Stampede. But many of you are probably familiar that you have local offices too. Your senator might have an office in the federal building complex. You might drive by a strip mall that has your congressperson's office in it, or one of them. These are constituent outreach offices. They can be a resource too. The constituent offices that are local often help people with simple federal questions. How do my VA benefits work, or am I using them properly? I have a Medicare problem. Can you help fix it? The offices do work like this. They can be a resource. But as we talk about, rather than kind of our individual issues, right now we're talking about that 30,000 foot view, changing the law. What does the policy say overall? And how do we engage Congress? And of course, every member can have an impact. All members should know about this. They have to work together. But Congress uses some key committees. Some members in their offices are assigned to work on healthcare issues specifically. In the Senate, they have a committee called the Health, Education, Labor, and Pensions Committee. That committee is led by Bernie Sanders, who some of you probably know from running for president, and Bill Cassidy, who is a gastroenterologist from Louisiana. That committee oversees the Department of Health and Human Services, medical research at NIH, public health at CDC, related activities. The Senate also has a finance committee that deals with insurance issues, private insurance, Medicare, Medicaid, etc. The House has counterpart committees. The counterpart committee, the Health Committee in the House, is Energy and Commerce. And I mentioned it because none of these really say health in them, or research, or patient care. The other counterpart committee in the House to finance is the Ways and Means Committee. So if you're making a visit, you will know if your members are on one of these key committees. Even if they're not, you should very much keep them engaged and speak with them. But if they are, they can have a disproportionate impact, maybe directly considering some of these issues that you're talking about, and can play kind of a more pivotal role. So specifically what we're talking about right now is the Cancer Drug Parity Act, a bill that we've been advocating for a few Congresses. We had a little bit of a quagmire, of course, over the past few years with COVID. We weren't able to visit Capitol Hill. Congress really wasn't working on any issues that weren't directly related to the pandemic response. Healthcare was very much oriented somewhere else. But now things have largely returned to normal. Congress is working on legislating again. They're looking at issues like PBM reform, and we can freely go see our members in person and talk to them about these issues and ways they might be able to help. The Cancer Drug Parity Act is a bipartisan and bicameral proposal, which means it's supported by the House and Senate, and it's supported by Democrats and Republicans. Any member should feel comfortable joining this effort. In the Senate, the bill number is S2039. It is led by Senator Tina Smith from Minnesota, who may be joining us for the Stage 4 Stampede, and Senator Jerry Moran from Kansas. It has 14 bipartisan co-sponsors right now. It had 21 in all of the last Congress. So we've almost caught up to the level of support we were at previously. But once again, there are 100 senators. So that means there are 86 senators that are not co-sponsors. We're going to help work to push those numbers up, make sure there's more support for this bill. S2039 means it was the 2039th bill introduced in the 118th Congress. Our opposition is often not a different group or a different point of view. It's usually simply the bandwidth it takes to move these issues forward. Congress can only work on the issues that are the most popular, have the most support, and can most easily move forward because of the limited time available and the amount of work they have to do. So once again, 14 co-sponsors is a great start, but if we were getting closer to 50 co-sponsors or 60 co-sponsors, we would feel very comfortable that this is one of those critical bills that they're going to be considering with their limited time and figuring out a way to move it forward. The House bill has not been reintroduced just yet. It was HR 4835 in the last Congress, and we just came out of a month-long, 6-week August recess where they weren't doing any work like this. So if we have a bill number before the Stampede, we will fold that into this request also. But the bill has been led by a congressman named Brian Higgins, whose name I managed to spell wrong on the slide, and spell check wouldn't catch that, and a congressman named Brett Guthrie from Kentucky. So they've been working together on this, and folks that we know like Debbie Wasserman Schultz from Florida that are champions have been involved too. That bill only had 36 House co-sponsors last time, so we're going to need to do more work to promote that bill on the House side and let people know why it's important. So what exactly are we talking about when we say the Cancer Drug Parity Act? On the left side here is the official statement on the bill. We are amending ERISA is what it's called, which is this Department of Labor health plan work to make sure that there's parity in cost sharing for oral cancer drugs that are no less favorable than anti-cancer medications delivered in other settings. This is a lot of legalese, but there's a fact sheet here that was developed by Tina Smith and Jerry Moran that spells it out very simply. And if folks probably glean from the name, this is about parity. So healthcare is complicated. You might have a plan that says encourages you to go to the hospital or encourages you to use infused medications. And you might have a plan that has different types of pharmacy benefits where you have a high out-of-pocket copay if you're buying oral cancer medications. And this doesn't make a lot of sense. This is one of those cases where innovation has outrun what regulation is act. Most of the therapies being developed now are oral cancer medications. So the idea that your insurance might be structured in such a way that you would be paying less or encouraged to go to an infusion center over just simply getting an oral cancer treatment is the problem. And it's what the bill is designed to fix. And once again, this is physician-patient relationship. You and your doctor might say, you should be on an oral therapy, or they might say, you are better off infusing. If that's done though, your out-of-pocket cost, your responsibility shouldn't change. Your healthcare should be the same no matter which option you are choosing to use. So the bill very basically expands oral parity to privately insured plans. So not just in the government, which Medicare, Medicaid are already resolving some of these issues, but employer-provided healthcare or ACA purchase plans. It prevents insurers moving forward from covering oral self-administer infused therapies differently using those pharmacy or hospital benefit or out-of-pocket cost calculations. And it tries to make sure that there's now a nationwide standardization. So no matter what state you're in, no matter what type of plan you have, it doesn't get shuffled. You wouldn't have, let's say that you had one plan and then you bought a different plan. Now everything changes for you. It doesn't make a lot of sense. So the bill, the parity is the key word, but more this is standardization. You and your doctor decide what's going to happen, and then your out-of-pocket costs and everything else are relatively stable. So I think many folks probably know why a bill like this would be timely and relevant and something they should consider either on its own or in some of these other healthcare discussions. Some of your members are already going to be a co-sponsor if we talk to them. The message is very simple. Thank you, but also please pass the bill. It's not simply enough to say you support it. Please work with your colleagues to move it forward. If they have not co-sponsored yet, if they're one of those 86 senators, co-sponsor the bill. Contact Tina Smith's office or Jerry Moran's office. Tell them that you want your name added to this effort. Democrats and Republicans in equal measure should be able to support this. And if you're in the House and they haven't dropped the new bill yet, offices can still get on board. They can contact Congressman Guthrie and they can tell them that they want to join the bill. They can become an initial co-sponsor. So when the bill is introduced, it will already have their name listed. They wouldn't have to add it afterwards. So you can always become an initial co-sponsor in the House, but Congressman Guthrie, since he's been the longtime leader on this, would be the right office to talk to get in on the ground floor in that regard. So we are going to take a moment to answer any questions. I do want to flag our upcoming activities, though. On October 4th at 4:30 Eastern, there'll be an hour-long, more comprehensive Stampede kickoff session. We'll review how to make a visit again. We'll review Civics 101 again and the issues. We'll also talk about a lot of logistics for the upcoming event. If you're doing the Stampede on October 17th at the hotel at 3 o'clock, there'll be a mandatory kickoff meeting. So even if you've done these sessions, if you signed up to do visits, this is the time when you start to meet your teammates. This is when you get your schedule. So the meeting at the hotel is mandatory. It's not something, I apologize if anybody was planning for this, but it's not something that can be excused because you were part of one of these webinars. So please, we hope you'll join us on October 4th for the kickoff. We certainly hope to see you on October 17th. If you're not doing the Stampede and maybe doing a virtual visit later in the year, there'll be some more information for you as well, but I hope that this is helpful. So I'm going to take a pause there, stop sharing my screen, and hand it back over to Sonia, and I expect we'll have a couple of questions today. So thank you very much.